Good afternoon, everyone, and welcome to Grand Rounds. My name is Tom Felden. I'm a chair and organizer of Grand Rounds. Thank you very much for joining us today. We'll get straight on. I'm very pleased to welcome to Grand Rounds today the neonatal team. I was just talking before we went live, as it were, that we don't see the paediatricians very much in Grand Rounds. They have their own teaching program that they call Grand Rounds that they organise. Is very successful. But Grand Rounds isn't just adult medicine. It's all of medicine, and as you know, we have a wide range of topics and a broad curriculum, as it were, including public health and global health, sustainability, updates on clinical practice, research, educational products, lots of input from the medical school. So it is hopefully is a broad church that appeals to a wide range of our community. But it's always nice to have departments along who we've not heard much from, and we have not heard from paediatrics for quite some time. And I was delighted when Lauren reached out to me earlier in the year to ask if she could have a slot to talk about family integrated care, a thing I know 2/3 of nothing about. So it's going to be a school day for me. She's joined by Tanya Dunbar, one of the community liaison nurses, who hopefully is here. There she is. Thanks very much for joining us, Tanya. If you have any questions, then please put them in the chat. We can go through the questions at the end. Please keep your microphone muted during the talk to prevent feedback, and then you can provide actual feedback at the end. So Lauren, thank you so much for joining us, and I'll leave things with you. Thanks so much.
Great, thank you very much, and thank you for asking us to talk, and for everybody for coming. So my name is Lauren Shaw. I'm one of the consultants in the neonatal unit in Nine Wells, and I'm hopefully going to be joined today by Tanya, who's one of our community liaison nurses. And we're going to talk to you a little bit about family integrated care. We're going to share with you what that means for us, and also ask if you would consider what it might mean for you in your service and your department. Let me just see if I can get this to move on. Oh, there we go. So the aims of this talk are really to set the scene. So some of you may have experience of neonatal units, some of you may have none, and this will be all new to you. So really just describing what it is that our service does and what we do for the babies and families of Teesside. Talk a little bit about what family integrated care is and the impact it's had on our practice and our service, and spend a bit of time thinking about how that has evolved over the last few years. And lastly, I would like to think about how it might impact on your practice and your service, wherever that might be. But the first thing I would like you to do, and I don't know how good people are or how willing people are for audience participation, but I wonder if people could go to menti.com, which is Mentimeter for people that are familiar with it. You pop in that voting code that's there and consider this question over the next little while and pop some answers in. And the question is that if you were unwell, vulnerable, confused, or worried or afraid, who is it that you would want to be beside you? Thinking very much not as a health professional, but as a human and a person, who is it that you would want with you? And we'll hopefully get some answers that we can talk about at the end. Okay, so we are the Nine Wells neonatal team, and we are based on level 6 in our, very happy to say, newly refurbished neonatal unit. We deal with about, Teesside has about 4,000 deliveries or births a year, and we have about 350 to 450 admissions a year. And our staff is made up of about 100 people, give or take, and that's mostly consisting of neonatal nurses, but also consultants, trainees, allied health professionals, administrative and clerical staff. And we have really strong links within women and children's, with maternity, obstetrics, paediatrics, and with the wider community paediatric service as well, and occasionally with adult services. So what is it that we do? So we look after families right from the very beginning of their pregnancy journey. We get involved with our obstetric and midwifery colleagues in fetal medicine and antenatal counselling, often when parents are going through difficult times and unexpectedly challenging times. If they have a new diagnosis that they weren't expecting, we would be part of the team counselling them through that. We are present at resuscitation and stabilisation of babies at birth, and that can be from really extreme premature babies all the way through to unexpectedly unwell term-born babies, or babies with either known or newly diagnosed congenital abnormalities requiring help and support at delivery. We are an intensive care unit, and we also provide high dependency and special care for our babies. And the babies we look after are wide spectrum. You can see in the first picture there that this is a very extreme term infant, probably around 23 to 24 weeks gestation, weighing about 400 to 500 grams. But we also offer intensive care to bigger babies, all the way up to, as I said, unexpectedly unwell term-born babies. As well as intensive care and high dependency, we offer care to babies on the postnatal wards who may be unexpectedly unwell, but we also offer routine baby checks and support our midwifery colleagues in providing that service. We have an area called transitional care, which is a great kind of hybrid of us and maternity, where there may be a group of babies who need some enhanced care that can't be given on the postnatal ward, but we don't want to separate them from their parents. So we provide this area where we can do both midwifery and neonatal care. But it tends to be our weller, slightly bigger babies. Being an intensive care unit, as you can imagine, we have to develop skills and expertise in end-of-life care, and we manage that really closely with our neonatal nursing team, and also have great links with our palliative services in the community and through paediatrics. And as Tanya will talk about later, we provide community support to our babies who've been through the unit. Some of them need enhanced care going forward, as you can see in the picture, perhaps in the form of home nasogastric feeding or home oxygen. And we have a team of nurses who are able to provide this liaison service for us. And lastly, we're also involved in long-term follow-up. We look after all of our babies who've been through the unit, particularly thinking about our premature babies who require quite close monitoring of their neurodevelopment and their milestones. And this is a little picture of one of our babies who was with us, born at 26 weeks, who's now practicing on his balance bike. So it's great from a clinician point of view to be able to see these babies develop and grow. So just moving on, so what is family integrated care? So family integrated care is really a model of care that places the parents at the centre, at the heart of everything that we do, and is an extension of the principles of family-centred care or patient-centred care, which you might be more familiar with. And the goal of family integrated care, or FI care as we call it, is to create a partnership and collaboration between parents and staff, and really promote that parent-infant bonding and interaction to allow parents to become empowered. And what we want them to be empowered to do is be part of the primary care team, looking after the babies. And that's really moving away from the traditional care delivery, where we think it's only highly trained health professionals that can provide that care. The value of parents is really, really sought after through family integrated care and recognised. So what's the evidence for it? So this has really been a new concept over the last maybe 10 to 20 years, and it stemmed mostly from a group in Canada. I think people around the world have been doing elements of it, but they really brought it, they labelled it, and they gave us a framework to help implement it. And there's more and more studies showing that models of FI care, of parent engagement, consistently associated with improved feeding, improved growth, improved parental well-being, and it's been shown to be a model that's safe, adaptable, and entirely feasible. And the group in Toronto were one of the first to produce a family integrated care pilot study. And what they did was request that parents be present at the bedside, providing infant care for a minimum of 8 hours a day, which sounds like an intense period, but a lot of our families are here for much longer than that when their babies are here. They asked that they attend a block of education sessions over 3 weeks and participate in daily ward rounds. Through this study, it was also extended to include international sites, and they did a clustered randomised controlled trial, including Canadian and Australian neonatal units, in which the parents were actively engaged in infant care for a minimum of 6 hours a day. And what both of these studies demonstrated was that family integrated care models were associated with improved infant weight gain, improved infant breast milk feeding, and reduced parental stress and anxiety. So that really set the path for further studies, really looking at what other outcomes can we improve. So there was a randomized controlled trial of FI care in some Chinese neonatal units involving over 600 preterm babies. And what they found was that their primary benefit they observed a primary benefit of reduced length of stay, but also additional benefits of faster establishment to suck feeding, reduced oxygen requirement and need for ongoing respiratory support, reduced rates of infection and therefore antibiotic use, and reduced rates of hospitalisation, and an overall decrease in healthcare associated costs. Here in the UK, a pre and post intervention analysis in the UK demonstrated similar benefits with establishment of earlier feeding and a significantly reduced length of stay. And if you consider that a day of intensive care in the neonatal unit costs about £1,000, some of our babies are in hospital for over 100 days, that's not an insignificant amount of money. And then finally, just a recent study in the Netherlands involving over 1,000 infants receiving FI care. They have a very aspirational model in that they're single rooms with one-to-one nursing and their parents stay beside them at all times, showed lower infection rates, more exclusive breastfeeding, and again, reduced length of stay. So real tangible improved outcomes for these babies and families. Our professional group, the British Association for Perinatal Medicine, recognised the value of family integrated care and the real push for across the country to have some sort of structured framework to allow them to establish it within their own unit. So they produced a framework for practice that was published a couple of years ago, and it really held 5 key principles, and the first one being partnership with families, really at the centre of that. So what I'm going to do is talk through the different elements of what their recommendations are, and then what we have done in Teased to implement these. So the first one that they've recommended is partnership with parents, and that really is key. And the key element of that is forming positive relationships with parents and really helping nurture and support them into being caregivers for their babies. We want them to be actively involved in ward rounds and planning, decision making, and we want to use technology where we can, both within the unit, but also to seek parents' experiences and feedbacks, and to provide parents with opportunities to give us feedback and share their experiences when we can. So within Teased, one of the first things that we did was we wanted to make parents feel welcome. And partly of recognising that is that they are not visitors. We do not dictate to them when they can come and see their baby. We have recognised the value of them being in the unit and have given them the same swipe card access that all staff in the unit have. So they can come and visit their baby 24 hours a day for as long as they like without restriction, which is a huge shift and really only come into practice over the last 3 or 4 years, but a hugely positive shift in how we manage parents. We try to get extended family involved. We have encouraging families, including siblings and grandparents, uncles, aunts, friends, to come into the unit. And we use resources available to us, because you can imagine being in a clinically intensive care environment, worried about your baby, but also trying to manage your 2-year-old can add to stress in some ways. So we try to engage resources around the hospital. So this picture shows us having some collaboration with Radio Lollipop, who would come and provide sibling engagement sessions. It's very easy to recognise that this has been a bit plagued and put back because of COVID, but we have tried really hard to protect our visiting for extended family. Unfortunately, it's only had to be stopped over COVID and only recently reintroduced, but we have worked really hard across our network and with the government and with different health boards to try to protect parents' access to their babies, and so far we've done really well with that, I think. Once parents are here, we want to really engage them early in the process. If time allows, and we know that babies will be coming to us after delivery, we try to offer parents early access to the unit through antenatal tours. We have an online virtual tour of our unit now, which is really good to see, because we've had a lot of work done in our unit, a big refurbishment, which has really changed our environment. We also offer parents welcome packs when their baby is first admitted, and within our welcome packs is a whole collection of stuff and resources that they can use. But one of the most important things is a booklet that really sets out from the onset what our philosophy for families in the unit is. We want them to be welcome, we want them to be part of the team looking after their baby, and we're going to show them and support them in how to do that, and that's really important for us to share really early on. We also use technology quite a lot in our neonatal unit, and this has been a real innovation, not just within our unit, but across Scotland and the UK over the past few years through a service called vCreate. And some of you might have heard of vCreate before because its uses are now extending out beyond the neonatal unit. But what this is a service that allows secure video messaging and pictures to be used between ourselves and the bedside nurses and the families. And the interesting way that this came about, and again, you may have heard Neil Patel, who is a neonatologist in the Children's Hospital in Glasgow, was really fundamental in pushing this innovation forward. And he had a family where the dad said that, why is it that he can take his car to the garage and the garage will send him a video of what exactly they're doing with the car, but he can't get the same for his baby who's in the neonatal unit. And that really sparked a whole conversation and collaboration with a digital team and the formation of vCreate. And vCreate is now used in nearly every single neonatal unit across the country. And as I said, extending out beyond into international units and really making huge leaps and bounds in how that technology can be used in other services. It's starting to be used in the epilepsy service and neurology quite heavily for patients being also able to send videos in the way as well as us sending videos out the way. So I just wanted to show you a little example of one of our videos. This was the nursing teams get really into these, and props are used, music's used, and the creativity that goes into it is just wonderful. And parents give such positive feedback for getting these videos, particularly if their baby has been really unwell or they may not have been able to access their units, particularly at the moment with COVID around. Some parents have been restricted if they have COVID. So this is one way that they can still connect with their families, and hopefully this little video will play. Lovely. I hope that played for everybody. The other part of technology that we've really started to increase our use of is Near Me, and we don't only use it for outpatient appointments now, but we also have started to use it for virtual ward rounds, recognising that a 9 o'clock start for our ward round is not always convenient for families if they have other domestic commitments at home, or if they can't come into the unit because of COVID. This is a way for them to continue to be involved. So what we would do is the team would go to the bedside. We would have we are all electronic records now, which we're very lucky to have. So we would have our systems open, we'd have the bedside nurse and the medical team, and then we would have an iPad with the parents on it as well. And that allows the parents to be present, to ask questions, to be involved in the decision making for the day. And it also allows them to see their baby and ask any questions that they have, or share any worries or concerns. And this is a really, this is just becoming embedded now with us, but it's a really useful way of communicating with parents. The other aspect of partnership with parents is co-design, and this is something that we've tried really hard to do over the last few years, particularly thinking about environment, pathways and processes. So for our environment, as I said, we've had our unit refurbished in the past few years, and we've used parents' input at every point throughout that, and a huge amount of the decisions that were made, from anything from the colour of the walls to the design of the artwork, some of which you can see throughout this presentation. All the artwork on the presentation is taken from our neonatal unit, to how the different rooms are designed that the parents have access to. We also consider them in terms of the actual physical environment, what would be good for them, what spaces do they need for themselves, for their own peace of mind and well-being. They're involved in our pathways that we make and our processes, for example, thinking about our outpatient clinics and how they access them. So at every point we try to include parents, and this feedback is sought from them in a variety of different ways. We sit down and we talk to them when they're in the unit. We use questionnaires, we use social media, and we also have these parent engagement sessions that Tanya might be able to speak a bit more to later on, where we have a group of parents, some past, some present, that will come along, share their experiences, share their ideas, sometimes what their challenges have been. We also look to getting negative feedback, because that's always something to learn, and sometimes more powerful than the positive feedback. And it's a great opportunity to catch up with parents, past and present as well. So Beyond partnership, one of the ways that we enhance that partnership is really to try and empower parents in the unit. And the principles and recommendations are that parents should be orientated to the service. They should have access to information which allows them to fulfill their role as a primary caregiver. And they need to have a clear understanding of what our philosophy is and what our expectations of them are. And we do that through different ways. We have individual skills teaching, we have mentoring at the bedside, we have a structured education of program for parents with parent classes, and we try to surround them or implement them at a time that's suitable for them. And it also is an opportunity for peer-to-peer learning. So these are all the recommendations, and we have taken that and run with it really. So we try early on through the visits that we talked about, through our welcome packs, to really orientate families to what facilities are available in the unit. We want to let them know what's available in the wider hospital, what accommodation is available and how they access that. And that's often jointly done with maternity or paediatrics. We want them to understand what their role is and that we want them to be involved in all aspects of care. And we start off very early by just giving them some information about what they can do. Because often, and you might know this from personal experience, when a family member goes into hospital, you feel like you have no way to help them, that you're out of control. And what we want our parents to do is to feel that they have some aspect that they can get involved in and be integrated into the care. So we try to give them that information really early on. We want them to know that they can learn the skills that are involved in looking after little early babies. So for example, in this picture is a baby getting a tube feed. We teach all our parents to do tube feeds. We also want them to know that they have a role in comforting their baby, particularly during painful procedures, for example. We don't chase parents away. If they want to stay and provide comfort, then we absolutely encourage that. Education sessions we provide for babies and their families. So this can be done either through bedside with one-to-one and the nurses love this role where they get to impart their knowledge and expertise and really mentor families and teach them and support them and to learn to care for the babies. We provide more formal education sessions where we have a weekly timetable, and these sessions are really, really useful and really variable. So it varies from things that are really straightforward and simple, like how to bath your baby, how can we improve breastfeeding, expressing, to much more things associated with well-being. It's really important for families to take time out, how they express their emotional needs, who's taking care of them, to kind of slightly more medicalized things. We get the allied health professionals and we teach the mums and dads how to position their baby with physio input. And then we start to teach them about a bit more medical things. So we teach them about the equipment that we use, what breathing support is, what the ultrasound scans are. We teach them about medicines. What medicines do their babies need? Why do they need them? And how do they give them? Because ultimately we will be teaching the parents how to give medicines to the baby. We also teach them about CPR. See what's on the next one. We teach them about immunization. So a whole host of things, of information and resources that parents can access as they choose to. So there's no requirement to come to this. Some of these sessions are really engaging for parents, and some of the parents are just don't want to do it, and that's okay. It's all about supporting the families to do what they can do for their baby. Some parents find it really useful to be able to record what it is that they've learned so that they can feel confident that they're doing it. And again, on our welcome booklet that we give, we have pages where there are parental skills checklists. And even if they learn them, they don't have to do to provide it as much as we support it, because for some families it's just too much, and it's really important for us to understand that, so they can express whether it's something that they want to do or at this moment in time it's not something that they would want to do, and we take that into consideration. Finally, in terms of empowerment, something that's so important to us is bonding and family connection. You can imagine that if you have never had a baby or experience of a neonatal unit, coming into one where there's, it's such a busy, scary environment, no matter how much we try to make it family friendly, there are incubators, there are monitors, busy, there are alarms going off. It can be really intimidating. And there's lots of physical barriers to the families getting involved with their babies. So there's incubators, there's tubes, there's wires. So it can be quite difficult to try and encourage parents to actually get involved, to get their hands in, to touch their baby. And skin to skin is something that we really encourage with our families. And you can see in the first picture here that this is a ventilated preterm baby who's perhaps got umbilical lines and certainly has a cannula, has NG tubes in. And so to a parent, it's really scary, the thought of holding that baby. But part of our role as a team is to make them understand that it's actually the benefits of holding their baby and having skin to skin outweigh the risks of having them out and the fear of having them out, because it's so important for the families. And so we support our families to learn how to do this. And sometimes they have the babies out for hours and hours at a time, and it's lovely to see. Other things that we can do to support bonding is, you can see this little baby in the top right hand corner here has a bit of fabric over him, and what that is a comforter. So it's a bit of fabric where we give one to the mum, one to the mum or partner, one to the baby, and it gets the baby's scent on it, it gets mum's scent on it, and then we switch them over. So there's this constant connection between mum and baby. The scents are there, and that helps in terms of well-being. It helps in terms of milk production and expressing and comfort to the baby. So sensory things, sensory engagement with the families and babies is so important. We're really lucky in Scotland that the Scottish Book Trust have also recognised this, and they will provide all of our families with books so that they can sit at the bedside and read to their babies. And again, this is such a lovely experience for both families and for the babies, and also for siblings and extended family to get involved in. The next kind of principle is thinking about the environment, and I've already touched on this a bit, and the recommendations are to have a welcoming environment, and to have facilities for parents where they can have dedicated rest space, kitchen facilities for heating and storing food, 24-hour access to their babies, somewhere where mums can go to express either in privacy or at the bedside. And they recommend having facilities to room in, such as transitional care, and also to have facilities available for end-of-life care. And we're very lucky through our new refurbished unit that we can provide all of that for families. The other part of environmental considerations are in terms of expenses. So having a baby in a neonatal unit is a really difficult time for families. Some of these babies, as I said earlier, are with us for months and months and months, and that has a huge financial burden associated with it. So several years ago, the Scottish Government produced a neonatal expenses fund, which allows families to claim back expenses to cover for transport, parking, and food for any days that their baby's in the neonatal unit. And I think there's actually just been some changes to that in recent days that allow that to be extended to babies who are in transitional care and also on the postnatal ward. So a huge leap forward for these families who often struggle financially travelling back and forth, because particularly in Tayside, we cover such a wide area and not all families have easy access to transport. Next principle is focusing on well-being, and this is something that I think we are really progressing in Tayside. So what the recommendations are thinking about families and staff, not just families, having access to specialist psychological and mental health support. Huge recognition of the impact of on families of having a baby in neonatal services, particularly for those families where they're unexpectedly seriously unwell, or they're born really preterm and have a really long, protracted, difficult, often traumatic course for these families. And up until recently, we have had no provision to be able to provide any support to them. But I'm very happy to say that in the past few months, we have now an association with maternal, perinatal infant health and community services have got a new psychology service being established, where we will be able to link in with that, which is just fantastic. Other things going on in terms of well-being in the neonatal unit for parents. So we signpost to resources. Lots of charities out there provide resources for parents, including kind of peer resources and sharing of experiences. We use Facebook and social media to help parents link in with other peers. We talk about practical and emotional support that's available in-house. So we use the chaplaincy service a lot and are really well supported by them. We have a service called Parent to Parent, which uses key workers who have had experience of babies children who are unwell, and they share that experience and support parents. And we also have Bliss, which is one of the biggest newborn charities or charities for preterm babies in the UK. And they have Bliss champions, which are volunteers who come into the unit to really just lend an ear to families and be able to sit and listen to them and share experiences. So we're very lucky. And as I said, the new psychology service, I'm very excited to have access to. We also recognise that for staff, particularly in light of COVID, that staff wellbeing really needs to be considered. We are an area of, it's a high risk area, it's a challenging area to work in, it's highly emotive at times, and we need to make sure that our staff are looked after and that their well-being is thought of. And we're very fortunate that we have had this recognised, particularly in our nursing streams of work, and have an established wellbeing team created. And really what their plans are to try to find ways that staff can find connection, value, balance, fun, confidence in their roles, and formal support as needed to help with their well-being. We are able to also access the psychology service that we have, and this is hugely beneficial, particularly when it comes to debriefing challenging events such as bereavement or, for example, resuscitation that didn't go as planned. And finally, just thinking about the culture in our unit. So all of the things that we've talked about have really become ingrained in and changed the culture in our unit. And what it is that BAPM have recommended is that education and training activities for all team members are available, really pushing forward with the philosophy of family integrated care, that all of the staff should be have training and induction in family integrated care, and that you have identified family integrated care teams and champions, and that throughout that parents are engaged in all aspects of development and delivery of the service. And I think in Teased we've managed that really, really well. We have a dedicated family integrated care team, and they have managed to ingrain the philosophy of family integrated care through induction, through teaching, through training for all new staff, whether that's clinical staff, administrative staff, nursing staff. Parents are involved in all aspects of planning of our service, and we've really moved forward with engagement in parents through the use of social media. We have a Facebook page, which I should have put the link to, but I haven't, but it's easy to find. So Ninewell's NICU. And through this, we're able to share what it is that we're getting up to. This is our team celebrating World Prematurity Day, and we share these pictures through our Facebook page with our families. We celebrate holidays. We have it's a picture of a Christmas party that I think Tanya could speak to, because she organises where our past and present families come and celebrate the festive period. We use it to connect with the wider community who may not necessarily have had babies in the unit, but want to do something to help support our service. So we have a huge collection of volunteers who will do knitting of clothes. What you can see in this picture is bonding squares. So the squares that are materials I was telling you about that we use to enhance bonding. And it's really nice for them to be able to see how we use the things that they do for us, because their time is so valuable and we're so grateful for them, that it's lovely for them to be able to share in that. We also use it for Facebook pages to allow families to engage with us and help them celebrate. For example, some lovely pictures here celebrating Neonatal Intensive Care Awareness Month. We use it to recognise and raise awareness for more challenging circumstances, such as Baby Loss Awareness Week. And we also use it to help update staff and families about the babies. And loads of our families, past and present, will write lovely messages to our team. They'll share pictures of how their babies are doing. And it's such an absolute delight to see, not only for the staff that are there, but also for current parents, to let them see the other journeys that families have been on and what they might expect. So a really, really useful way to engage with the community of parents and wider. We also use it when our kit goes missing as a way to help get things back as well, which is also really useful. It's a picture of a couple of apnea monitors that went missing and we needed them back, and a gentle prod to the families to help give us back our equipment. And I think I might pause at that moment, if that's okay, just to ask Tanya to come in and to see if she can share some of the thoughts that she has had and experiences of family integrated care, if that's okay, Tanya.
Absolutely. I've worked in neonates for 20 years and I was a neonatal nurse, and I loved the high-end, exciting end of neonates. I liked an intensive care baby, and I loved nothing more than doing my cares, doing my feeds, putting all my drugs up, doing it all. And I had no time for family-centred care. That was my job. I was a neonatal intensive care nurse. And then someone said to me, no, we need to teach parents how to do the tube feeds. We need to have the parents coming in to get them out for skin to skin for long periods of time. And I thought, oh, do you not know how busy I am? I'm a very busy woman, you know. And over the course of the last few years, we've all changed our attitude. We are now not doing all the tube feeding. We are now not doing all the nappies. We are teaching and really encouraging and supporting families. So our job has changed. It's unrecognisable to what it was for me 20 years ago. We are now about giving the parents the whole world for their baby, so they can kind of be the best expert that they can be for their child. And they don't have to be here all the time 24/7. They've got loads and loads of opportunities to engage with us through Recreate or coming on doing the virtual ward rounds, giving us a phone. And what this has done is, for me, now that I'm more in the community side, I'm seeing families going home, and the confidence that they have in looking after their baby is phenomenal. It's absolutely inspiring, actually, because everybody is an expert in babies. Everybody knows a baby, everybody knows how to look after a baby, but nobody knows how to look after your own baby. And this really has gave parents the confidence. They know, I know how I want my baby to look after. I know what I want for my baby, and I know what I want you to do for my baby. And they've got that, and they know how to get help if they need it. They know how to do all the feeding at home. Lots of babies go home tube feeding now. A lot more babies go home in oxygen, and that's because family are ready to take their babies home so much earlier than what they were 10 years ago. I looked back at my figures a few months ago, and we had 2 or 3 babies a year going home in oxygen. At the moment, I have got 9 babies at home in oxygen, and that is solely because parents are so much more empowered at looking after their babies. They're so much more confident in doing it, and that happens the moment they said good morning to them when they come through the door in the mornings. And that can be everything from giving them the little cuddle cloths so mums take them home, so they've still got something to feel home, so they don't feel guilty about them. They've got absolutely everything, and they know that their journey doesn't end when they finish in the neonatal unit. They know they've got the ability to contact ourselves if they've got anything to worry about. They know that they've got the parents' engagement evenings, they've got the Christmas parties, the toddle waddles, they've got loads of different things. So they know they're not just being abandoned at the door. They've got all that carrying on for them the moment they leave. And it's
New
so
community.
Yeah, it is. The whole job's changed, and it's absolutely great to see families just absolutely. They love coming up to see us when they come up to the ward rounds in the morning, and when they come up to do the outpatient appointments before COVID. They used to come up to see us and just say, "Look how well we're doing." Now that never happened before, but they have got the confidence to show off their babies now, confidence to show how great a job they've done, and they should be so proud of themselves for what the work they have done. The nurses here now are totally on board with FICare, whereas they weren't a few years ago. But it takes time.
I've got some interesting photos coming up of that, actually, Tanya, and that just leads probably quite nicely. Thank you so much.
That's okay.
The next part, if I can get this to go forward. Oh, there we go. So just a very quick summary of what I've talked about, because I'm conscious of time. So really, who does family integrated care help? So we know that it helps the babies. We've got improved outcomes for them: breastfeeding, better weight gain, better growth, early discharge, reduced time on respiratory support, reduced infection, length of stay, and overall cost. It helps families, as Tanya was saying, with improved bonding, improved confidence in parental well-being, reduced financial hardship, and really forming that foundation of a strong, supportive relationship with families right from the outset. For staff as well, it makes our life so much easier. And as Tanya says, there was a lot of resistance to this, that it's just going to add to our workload. But in fact, it reduces our workload. It takes a burden off of the nurses to free them up to do other things. It provides our team with opportunities for professional development and allows us to have better relationships with families, and an overall sense of value, pride, and achievement in supporting families that perhaps wasn't there previously. And for the wider network, it definitely has impact. So over the kind of move of family integrated care, we have a lot more sharing between units. If one unit has a really good idea for something for families, they'll share it and other units will adopt it. So lots more shared learning and experience, and all working towards the same goal for a more effective, equitable service across the country, and really trying to push for improved outcomes for our babies and families. But as Tanya says, it hasn't always been like this. And I don't want you to go away thinking this could never happen. My area of work, we would never be able to do that. Because if you think back to pictures like this, and this is in the not too distant past, there are certainly nurses working with our unit who remember this terrible thing, which is the viewing corridor. So there was a time where parents were not encouraged to be in the unit. They weren't welcomed in the unit in the same way they are now. They had restricted visiting hours. They were only, if they were allowed in, they were only allowed in at set times. That was at our convenience. Dads weren't encouraged to come in, and extended families certainly were not. They had to come to the window to view their baby. And if they were allowed to hold their baby, it was for short periods, and they had to wear kind of surgical gowns to be able to do that. And the concept of skin to skin just didn't exist. And as I said, no other visitors were allowed. So this has been a huge revolution that has really started over the last, or taken hold over the last kind of 10 to 20 years. There's been a massive shift. And I want to leave you with two things. The first one is this video, which is just a couple of minutes long, but this is Shu Lee. So Dr. Shu Lee is really the guru or master of family integrated care. He works with a group in Toronto. And what he says not only resonates with the neonatal service, but I hope you would agree resonates for other services for other patients. So I'm just going to play this video. Please bear with me because it is just a couple of minutes long, but really, really useful things that he talks about.
Care can only be delivered by professionals who are highly trained, and particularly in intensive care settings like the NICU. In FICare, we are bringing families in to become part of the care team, where they are the primary caregivers. That's a shift, a big shift in thinking, a paradigm shift. Essentially, it says that we made a mistake. It cannot be that only professionals can provide that care. In fact, families have a very important part to play in the care of the baby. And they do that through participation in many things. In providing the care itself, in providing insights into how the baby is doing, because they are the ones who are closest to the baby on the daily basis and know the baby really well. By discussing with the doctors and nurses how best to care for their baby. And by also involving themselves, they are contributing not only to the welfare of the baby, but actually also enhancing their own health, because the family is also affected by the baby's illness. It also gives the doctors and nurses a very different perspective of how to interact with the families and how to care for the entire family as opposed to just caring for the baby. So it's a big shift in thinking. I think, first of all, that we have to change the culture of how doctors, nurses, and other health professionals interact, not only with the families, but with themselves, so that they can better integrate and embrace the role of families in the unit and in the care of the babies. That's the first thing. The second thing is that they have to think about how best they can use this new way of caring for babies to support families, and how families can also support themselves. Because we are finding that a lot of the families interact on a very different level, and they provide mutual support in a way that we never saw before. And this carries on beyond the NICU, so that that kind of support interaction will have enormous benefits beyond the NICU in the lives of the babies and their families later on. And finally, I think that this is a concept that needs to be embraced by all the healthcare system and not just by the NICU. I think what was most surprising to us, which we did not expect, was the engagement of the parents, because we thought that there were going to be limitations with respect to how many families can actually participate in this and can commit the time to do so because of other obligations. In the pilot study, we found that 80% of all eligible parents actually participated or wanted to participate. What it suggests is that there is a broad support and interest in this. And so I think that going forward, we will be able to make sure that the program can embrace all families that want to participate in such a program. I think that this will cause people in all areas of healthcare to ask themselves, have we got a model right? In thinking that healthcare is something that health professionals direct and patients comply. I think it has got to be a partnership where, in fact, families, patients are deeply involved in their care and take a much greater role.
Okay, so the last slide that I want to share, and then we'll stop for questions if I can get it to move on.
In the past,
here we go. So I would just quite like to set a challenge to you. Obviously, neonates is quite a niche division. We're a small department and often might be perceived to be able to do things that other services can't. But I would challenge you to ask yourself, how could you better understand the needs and wants of your patients beyond what their illness is, beyond what their admission diagnosis is? What value could allowing families then bring to your own personal practice, to your service, to your department, to your team? How could you use technology to engage more with families and help support your patients, perhaps thinking about supported earlier discharge or getting families involved in ward rounds? And what challenges would you predict if you allowed families to be more involved, and how might you manage them? So really just some questions for you to think about. I'm happy to discuss. I wonder if we might go back to the Mentimeter. So just bear with me and I'll try and share that. And I'm hoping that people have tried to engage in that. So let's just see. Now is the time to see if people have. Oh, there we go. Okay. So I think this is a really important thing for us as healthcare professionals to think about. Often we consider them as patients, but if we were in their shoes, who would we want with us? And how do we as a service help that? Because it's time that we recognize patients as more than just a diagnosis, but thinking particularly with realistic medicine in view, family patients are much more than their diagnosis. They need to be at the center of it, and we need to support and recognize that they are part of something bigger, and that something bigger is their family, and that has such an impact on their well-being and health. Thank you. That's me finished. I'll stop sharing. Happy to take any questions with Tanya's support.
Thanks very much, Lauren, and Tanya as well. Lots to think about in there. I had the privilege of having a brief tour of the new neonatal unit a few months ago, as I had one of my patients had a baby and didn't actually have to go to NICU in the end, but we went to visit in a way to familiarize ourselves with the environment, and much of what you're talking about is so that it's not, we don't just arrive, even as doctors who are any healthcare professionals not used to being in that space. And I was pretty apprehensive trying to push through that door, thinking, what am I going to find behind this door? And actually it was an area of calm and as you've described, parents really just part of the team and wandering around, doing things, being there. It was a really interesting environment, very different from any ward environment I've ever worked on. There's one question. Evie, do you want to say your own question, Evie, or shall I be the voice of Evie?
Yeah, I can be. Hi, thanks so much. It was fascinating. My question is whether you're actually monitoring the uptake of family awareness sessions, whether you're monitoring any socioeconomic indicators, just to see whether there are any health inequalities attached to that. Thank you.
Yeah. So for the first part of that, and I think Tanya will agree, COVID has been the blight of everything in the hospital, and everything good that we had progressed with our family integrated care had to kind of go on hold during that. So because of COVID, we had to stop our family awareness sessions, parent education sessions. Certainly in the group setting, the bedside teaching continued, but the group setting had to be put on hold. But before that, I think Engagement was quite variable. There were some sessions that I think families engaged really well with, and other sessions that I think made them a little bit nervous. So perhaps sessions that were a bit more medicalized might have made them a bit more nervous. But then our role in that is to try to demystify that and take away the kind of scary elements. And it would really depend where they were in their journey as well. So parents, perhaps if their baby had, was being unwell or sick at any particular time, they'd be less likely to have the mind space to be able to come and engage in these sessions. Whereas if they were going through a period where things were going well, or they were preparing for discharge, much more likely to come. Tanya, I don't know if you want to comment on that.
Yeah, I would agree. I mean, no session, even if there's just one parent that turns up, it's still a worthwhile session to do. So to say, we've got one parent that's not worth doing, it certainly is if we're teaching them how to do CPR and it saves their baby's life. You often find that when babies are getting ready for being discharged, the families are much more relaxed about the time that they've been in the neonatal unit, and they kind of engage a lot more, coming to the little groups for doing the CPR, finding out about medication, because they're becoming aware that they're actually going to take on a different role with that. Whereas the parents are quite love doing the one-to-one sessions that they do with the nurses at the bedside, teaching them how to do the baby's personal care, or for doing tube feeding and things like that. So I think it's a journey, and it changes quite a lot on how they are on their time in the neonatal unit. And sometimes as well, the parents actually come because actually they just want some different human interaction.
Yeah,
they're not just going for the teaching session, they're actually coming so they can actually come and sit around the table, have some kind of engagement with people, and actually have a cup of tea and a chat. It might actually be you go for one thing, but you do something totally different in the end as well. And that's absolutely fine. And parents support parents, and that's a massive thing.
Yeah, brilliant, just brilliant. Thank you.
And to the second part of your question, I wondered if you could elaborate a bit more on what you mean.
Yeah, I don't know. I mean, are they certain families from certain socioeconomic backgrounds more likely to take up the offer of those sessions, and particularly in regards to the more technical aspects of the care? Maybe, I don't know, I'm making it up, I don't know, I'm just
no, I know what you mean. I wouldn't say so, no. I think once families are in and comfortable, again, part of our role is to make sure that it's at the level that they can understand. Because we don't just go in and talk technical jargon to them, we try to make it in a way that they can understand. I would say one of the barriers that we're probably very conscious of is families where there's a language barrier, perhaps wouldn't easily engage as much. But again, that is a challenge for us to be overcome, and how we adapt and try to make it inclusive for everybody.
Yeah, no, it's brilliant. Just, I mean, coming from a human factors perspective, it's fantastic what you've done with your system. Congratulations.
It's been a massive team effort, and I have to say, it's we're very lucky in Teesside to have a team, a leadership team who are very supportive of this, and staff throughout the unit who are so engaged.
Yeah, thank you.
You mentioned COVID, and one of the things that I feel, and I'm sure colleagues in the acute medical specialties and surgical, I suspect everyone feels, is that it's been a real challenge to try to investigate and treat patients without their relatives anywhere near. And we have a different challenge from that you face, but getting collateral histories, being able to communicate with families, getting them on board, being team working is so difficult when you can't have visitors, and everything is had to do over the phone. And what's interesting is we've gone really quite far backwards in this because of COVID in the last 2 years, and whilst that's happening, have made huge strides and completely revolutionized how you work. So this is really interesting, and things that I think that in the, as you said earlier, the adult medical world, the grown-up medical world, we will need to take on board and think about how we do this as we open up a bit more in a post-COVID world. I think that what you've talked about here is really, really very interesting. Great food for thought. Well done on the work.
Thank you. There is in Teesside, just to quickly chip in, Tom, there is in Teesside a patient-centred focus group that is formed, and we discussed, so I gave a similar presentation to them. So there is a group of people who are trying to see how can we bring this, or some elements of it, appropriately into the kind of adult world, and how can you use the resources and innovations that we've learned from in your own areas. So there are baby steps being made.
Yeah, and one of the things we have tried to think about hard is family access for new parents. New parents get sick, and we do unfortunately see sometimes often women who have whose pregnancy has masked their illness in some way or other and can present quite soon after giving birth, and so they have a very small child, very small baby, and trying to make sure that they can have their baby in their room. And how do we manage that? And how do we manage that in a hospital that wasn't built for this, that has a limited number of side rooms, and those side rooms are needed for COVID contacts, etc. But we could I suspect we could talk about this for another hour, but we need to go. People have to be away. I put in the chat the Facebook page if you're interested in that. I put in there some Archie chat. The infrastructure changes could not have happened without Archie. The funding that's come through Archie from the work done by many people around this room and people who are watching and people around the hospital over the last 5 or 6 years to raise money for this change. That effort continues. Archie on Top of Scotland happens on the 4th of June, I think. It's a Saturday. If you're interested, the link is in the chat. Archie events, and then look for Archie on Top of Scotland. If you want to climb an Archie, so we're aiming to have somebody on the top of every Archie at 1 o'clock in the afternoon on the 4th of June. So if you want to do that, then please do go and sign up. And Paul Fettis, who's the champion of all this stuff, will be talking at Grand Rounds on the 31st of March, all about that. So tune in for that. Okay, I best go. I've got to get to clinic. Thanks very much, Lauren and Tanya and the entire paediatric team. Hope to see you again soon. Take care. Bye-bye.
Thank you for having us.
Our pleasure.